Assalamu alaikum. First of all, I would like to thank Dr. Shaimaa Afifi for being always a supporter, and thanks for Dr. Nada Dumyati for this opportunity. I'm Nesrin Muhammad, Assistant Lecturer of Tropical Medicine, Alexandria University. I was notified by a telephone call to assess a 65 years old Kenyan patient with rectal cancer presented suddenly with tense ascites, elevated serum bilirubin, and elevated INR. As being an impulsive person, the first thing that came to my mind that it's peritoneal carcinomatosis. While on my way to the clinic to examine the patient, I thought it may also be portal vein thrombus or repeated blood transfusion due to anemia of rectal cancer. He could have acute viral hepatitis, or maybe because he is Kenyan and receiving chemotherapy, he got activation of abdominal tuberculosis. Then I went to see the patient. First of all, I looked at his file. He is 65 years old, Kenyan, presented with bleeding per rectum in April 2024, free post-medical history and free post-surgical history. His colonoscopy showed the rectum is ulcerated till anal verge, pedunculated rectal polyp. The pathology showed moderately differentiated adenocarcinoma and hyperplastic polyp. The patient did MRI with full abdominal screen. The tumor was distance to anal verge was 85 millimeter, distance to the top of the sphincter complex was 34 millimeter, craniocaudal length 55 millimeter, morphology semi-circumferential, location from 3 to 12 o'clock. It's T3C with mesorectal fascia invasion, with extramural venous invasion, with lymph node N2B with 6 mesorectal lymph node, largest was 6 milli, inferior mesenteric artery node 2 in number, largest 6 by 5 millimeter. That's why the oncologist took the decision of concomitant chemoradiotherapy before the surgery. The CT chest was normal, so it's T3C, N2B, M0, no sphincter involvement. The whole body PET CT study showed metabolically active, rather short segment of rectum circumferential irregular neural wall thickening with exophatic component and few mildly enlarged perirectal, bilateral, internal, common iliac, and aortocaval lymph nodes, coping with active tumor biology. These tests are gene tests for deciding the patient would take any targeted or immunotherapy or not. There was no BRAF mutation, wild type, and MSS was stable. So the patient wasn't competent for any immunological or targeted therapy. The patient started chemotherapy. At first, he took oxaliplatin and capecitabine. Then concomitant chemoradiotherapy with the capecitabine. At this MRI showed regressive course, so the patient firstly was responding to this therapy. Then, during the concomitant therapy, the patient developed grade 3 diarrhea and dehydration. He was hospital admitted, then developed AKI due to pre-renal cause, which is the dehydration. Chemotherapy was stopped. The patient was managed by sandostatin and IV fluids and improved. And dose modification was applied to the capecitabine dose. After 1 month, the patient presented by tense ascites, lower limb edema, very mildly elevated liver enzymes, jaundice of mixed type, and increased INR. This phase which I saw the patient. So this is the approach when we have a suspected liver disease presenting with abnormal liver test. Either it's acute or chronic. Our patient was acute, less than 6 months, so it's either hepatic injury or cholestatic injury. Our patient has hepatic injury, ALT and AST were elevated, and alkaline phosphatase and GGD were mildly elevated. So this is the diagnostic evaluation. We should look for acute viral hepatitis, IgM and anti-hepatitis A and hepatitis E also, hepatitis B surface antigen and hepatitis B core, anti-HCV, and the tests for the autoimmune hepatitis, asthma, and ceruloplasmin, and alcohol history and drug history for DELI. So, and the second step, when we have acutely presenting ascites, we should take acetic fluid biochemical analysis and to see the SAG, if it's either high SAG or low SAG. If it's high SAG, 1.1 or higher, we check the protein content. If it's more than 2.5, it's either cardiac ascites or early Budd-Chiari or sinusoidal obstruction syndrome. And if the ascites protein is less than 2.5, it's cirrhosis or late Budd-Chiari. And if it's low SAG, malignancy or TB, pancreatic or nephrotic syndrome or protein losing enteropathy. This is the same approach. So I started by the echo, doing echo for the patient. I ordered an echo, and ejection fraction was preserved and mild diastolic dysfunction. And then I ordered ultrasound abdomen pelvis with Doppler on portal circulation. The ultrasound showed that the liver is normal size, homogeneous, portal veil patent, and the hepatic veins were also patent. And there is ascites and no cholecystopathy. So I started to do our lab workup. It's all normal except for the alkaline phosphatase and GGT were mildly elevated. Albumin level was low, 2.9, and hepatitis A and E, IgM were negative. So we excluded acute hepatitis. And also hepatitis B surface antigen and HCV antibody were negative. And this is the body fluid examination, the ascitic fluid tap. The patient was high SAG, it was 2, with a low protein content. And I did a pathology also to see if there's any malignant cells in the ascitic fluid, and it was free. So the next step was to order triphasic CT. I was at this point highly suspecting Budd-Chiari syndrome, but the ultrasound excluded Budd-Chiari or portal vein thrombosis. I didn't have so much trust in the radiologist, so I ordered triphasic CT, and it showed that the liver is mildly enlarged, showing mottled pattern of contrast enhancement, and there is focal lesion seen at segment 8, 5 millimeter, but it doesn't show the criteria of HCC. Maybe it's a fat sparing area. And there was thrombosis in the hepatic veins with involvement of the intrahepatic portion of the IVC. It was markedly attenuated, and there was gallstones as well, and the ultrasound showed there was no gallstones. So for sure the ultrasound was not accurate. So the case is solved. It's diagnosed as Budd-Chiari syndrome. It's defined as obstruction of the hepatic venous outflow that can be located from the small hepatic venules up to the entrance of the IVC. First, before starting the anticoagulation, we decided to do upper GI endoscopy, and the patient had grade 3 esophageal varices with risk signs. Endoscopic variceal ligation was done under complete hemostasis. Our initial management was beta blocker, Clexane every 12 hours, orthodeoxycholic acid, and follow up for the esophageal varices after 3 weeks of the first session, and we did intervention radiology consultation. So what is the management plan for any Budd-Chiari syndrome case? First of all is the medical treatment, as we mentioned. Then we could consider angioplasty, stenting, or thrombolysis. The third step, we could consider TIPS. And our last resort is a liver transplant. This is the EASL guidelines regarding the Budd-Chiari syndrome. Consider diagnosis of Budd-Chiari syndrome in any symptomatic or asymptomatic patient with acute or chronic liver disease. Doppler ultrasound is the first line of investigation for Budd-Chiari. Re-evaluate the patient with an expert radiologist in patients with negative imaging studies but has high suspicion of Budd-Chiari syndrome. Refer patient to expert centers, initiate therapy for complications of portal hypertension. Treat all Budd-Chiari syndrome patients with anticoagulation. And consider interruption of the anticoagulation before any invasive procedure. Consider angioplasty or stenting as the first line decompressive procedure in patients with short hepatic vein stenosis or IVC stenosis. And closely monitor this patient if they needed TIPS at any point. This is the medical therapy. We give low molecular weight heparin as a bridging therapy, then starting the vitamin K antagonist, Marivan or warfarin. The direct acting oral anticoagulants are not studied in the Budd-Chiari syndrome till now. So, as an overthinker, I started thinking beyond the cause. Why the patient developed Budd-Chiari syndrome? Is the malignancy, the rectal malignancy, enough as a cause for the hypercoagulable state? I asked the oncologist if he would like to investigate more, and he told me that his cancer colon is controlled now, and he doesn't think it's the cause beyond the hypercoagulable state. So he told me, yes, let's investigate more. So, according to the EASL guidelines, we have to investigate for thrombophilia, either acquired or the inherited thrombophilia. This is the scheme for the investigations. We should do the investigations for factor 5 Leiden deficiency, methyl tetrahydrofolate reductase enzyme mutation, thalassemia, protein C and S deficiency, and antithrombin 3 deficiency. And the phospholipid syndrome, lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein. I started doing some of the investigations so not to be a burden on the patient. I started with antithrombin 3 protein C and S, they were negative. Then the antiphospholipid syndrome were negative. Then factor V Leiden and methyl tetrahydrofolate gene mutation, which was positive. He had mutation. So, was the methyl tetrahydrofolate reductase mutation responsible for more than the hypercoagulable state or not? The answer is yes. There are some papers stating that the methyl tetrahydrofolate reductase gene polymorphism is responsible for the capecitabine cytotoxicity. So the patients developed grade 3 diarrhea and severe capecitabine toxicity because of this gene mutation. These are some papers stating that correlation. So the experience I acquired from this case, not every case of ascites among colorectal cancer patient indicates peritoneal mets. Consider vascular diseases of the liver. Re-evaluate the patient with higher imaging techniques in cases of negative Doppler when the case is highly suggestive of Budd-Chiari syndrome. Never hesitate to ask a patient for upper GI before starting anticoagulation therapy. And this question should be directed to oncologists. Should methyl tetrahydrofolate reductase mutation be routinely done before starting capecitabine in any patient as a part of precision medicine or not? Thank you.